Hello, everyone, and welcome to this online training of local anesthetic systemic toxicity, or LAST. My name is Rachel Jager, and along with my nurse anesthesia classmates Shelby Beatty and Lakin Kittleson, we have created this project for our Doctor of Nursing Practice program through the University of North Dakota. We appreciate your participation and hope you enjoy this presentation. Before diving into LAST, we must first have an understanding of local anesthetics themselves. Local anesthetics cause absence of pain sensation by reversibly decreasing the rate of depolarization and repolarization of excitable membranes or nociceptors. Local anesthetics inhibit sodium influx through sodium-specific ion channels. This prevents the action potential from signal conduction, therefore causing the absence of pain. There are a variety of regional anesthesia techniques that utilize local anesthetics, including epidurals, in which the local anesthetic is injected into the epidural space where it acts primarily on the spinal nerve roots, spinal anesthesia, or a subarachnoid block, in which the local anesthetic is injected into the cerebrospinal fluid itself to act on the spinal nerve roots and part of the spinal cord, and peripheral nerve blocks, in which the local anesthetic is injected near a peripheral nerve to anesthetize that nerve's area of innervation. There are two classes of local anesthetics, the aminoamides and aminoesters. Some common amides include bupivacaine, also known as Marcaine, lidocaine, and ropivacaine. Some common esters are benzocaine, chlorprocaine, and tetracaine. An easy way to differentiate the amides from the esters is that amides have two eyes. As you can see, each of the three amides have two eyes with them, whereas the esters each only have one eye. It is also more common to have an allergic reaction to esters, so it's likely that you will typically see amides utilized for things such as spinal and epidural anesthesia. This chart comes from Nagelhout and Elijah, which is a very well-known and often utilized nurse anesthesia textbook. The chart lays out the commonly used local anesthetics from each class, as well as their maximum dosage in milligrams per kilogram and their duration of action in hours. As you can see, there are a few max dosages that have with epi written beside them. This is referring to epinephrine, which, as we all know, is a vasoconstrictor. Epinephrine is commonly added to local anesthetics in order to decrease their systemic absorption and to increase the duration of anesthetic action. You by no means need to memorize these dosages, but it is a helpful tool to reference back to when you're managing a patient who has received a spinal or currently has a labor epidural in place. Systemic absorption of local anesthetics is determined by the site of injection, the dosage and volume, the addition of vasoconstricting additives such as epinephrine, and the pharmacologic profile of the local anesthetics. This slide lays out the absorption of local anesthetics from the most absorption to the least absorption. Now that we have a brief overview of local anesthetic pharmacology and absorption, we can begin to understand local anesthetic systemic toxicity, or LAST. Local anesthetics are generally safe and effective when limited to the site of therapy, such as tissue infiltration near a nerve or a plexus of nerves. However, if a large amount of local anesthetic reaches the systemic circulation, supratherapeutic blood and tissue levels can cause toxicity. This transit into the blood may be due to inadvertent or accidental intravenous injection or absorption or vascular uptake from local spread. LAST can also be caused from continuous infusions, such as epidurals, in which the catheter can migrate into the vessel or outside of the epidural space. LAST largely affects the central nervous system and cardiovascular system. The CNS symptoms will always occur first, with the CV symptoms following second. The higher the level of local anesthetic injected or absorbed, the worse the symptoms of LAST. While the incidence of LAST itself is relatively rare, the use of local anesthetics in obstetrical patients is quite common, making the potential for LAST very real. Roughly 71% of pregnant women in the United States received a form of neuraxial anesthesia for labor and delivery analgesia, according to a 2018 study. In 2017, Lin et al. Described the occurrence of LAS during epidural anesthesia as being estimated to be 4 per 10,000 procedures, and noted that pregnant women hold risk factors that make them far more susceptible to experiencing a LAS event. This last statistic does not pertain specifically to obstetrical patients, but we wanted to include the fact that despite the utilization of ultrasound, which has significantly decreased the incidence of LAS, 2.5 per 10,000 peripheral nerve blocks with ultrasound have resulted in a LAS event. It's important to emphasize that despite advances in technology, a LAS event is always a potential. It was briefly mentioned on the previous slide that obstetrical patients are at an increased risk for LAS due to a variety of anatomical factors. Some of these factors include having an increased cardiac output and a reduced plasma concentration, which leads to an accelerated local anesthetic absorption. Obstetrical patients also have an enlarged epidural vasculature, which results in a reduced epidural space. This reduced epidural space necessitates the use of smaller doses of local anesthetics. It's also interesting to note that bupivacaine has been shown to have increased cardiotoxicity in pregnancy, which results in a decreased CC to CNS dose ratio. The CC to CNS dose ratio is the ratio of the dose of the drug required to cause cardiovascular collapse compared to the dose required to cause a seizure. Bupivacaine has a relatively low CC to CNS dose ratio, meaning it's more likely to cause cardiovascular collapse.
We will now be shifting into the manifestations of local anesthetic systemic toxicity in the obstetric patient. It is extremely important that obstetric nurses are aware of when LAS symptoms can occur in their patients and what symptoms to be watching for. LAS symptoms can manifest immediately or can be delayed up to 1 hour after receiving a dose of a local anesthetic. LAS primarily affects the cardiovascular and central nervous systems and encompasses a wide array of clinical symptoms that can be complex and progress very rapidly. Early symptoms of LAS include circumoral numbness and tingling, ear ringing, vision disturbances, twitching, loss of consciousness, convulsions, coma, and respiratory arrest. Late symptoms of LAS include hypotension, bradycardia, prolonged PR and QRS intervals, heart block, and other cardiac dysrhythmias. LAS should be considered in any patient with an altered mental status, neurological symptoms, or cardiac instability following a regional anesthetic. It is important to mention that sometimes with administration of a local anesthetic, it is normal to see circumoral numbness, ear tingling, and/or lightheadedness. Be sure to alert the administering provider and continue to monitor for progression of LAS symptoms. Although CNS symptoms are an early sign of an impending LAS crisis, it is possible for CNS signs to be subtle or even absent, meaning cardiac symptoms would be the first to appear. Here we have included a nice chart showing how LAS symptoms progress with higher levels of local anesthetic plasma concentrations. Symptoms with smaller doses include the CNS symptoms covered in the last slide and move towards a more severe symptom profile, including respiratory arrest and cardiovascular collapse. Please remember that every patient could have different presenting signs of a LAS crisis, and CNS symptoms could be very subtle or even absent. The current treatment of LAS, recommended by the American Society of Regional Anesthesia and Pain Medicine, also known as ASRA, includes symptom management and an intravenous administration of a 20% lipid emulsion. The IV lipid emulsion creates a lipid sink within the patient's blood, forming a lipid bilayer that sequesters toxins of high lipophilicity, such as local anesthetics, in an expanded plasma liquid phase. An example we were given in school is to think of this reaction as creating a salad dressing-like environment in our blood, separating the oil from the aqueous components. If you have a patient experiencing a suspected LAS emergency, it is important to immediately begin following the ASRA checklist. The first step on the checklist includes stop injecting the local anesthetic. This is obviously only applicable if symptoms occur immediately. In such case, it would be pertinent to alert the provider to stop injecting. The second part of the checklist includes calling for help. It is very important to get all hands on deck to help with symptom management and emulsion administration. You should consider administering the lipid emulsion at the first sign of a serious last event. You should also call for the last rescue kit. It is extremely important for all working staff to know where this is on your unit. This includes CNAs and other techs to ensure in an emergency you have what you need as soon as you can get it. The third thing on the checklist is airway management. You should begin ventilating with 100% oxygen. Avoid hyperventilation as it lowers the patient's seizure threshold. You should also gather supplies for insertion of an advanced airway if needed. If symptoms happen immediately, the anesthesia provider should still be at bedside to assist with this. Next, you want to control the seizures. Administer benzodiazepines such as Ativan or Versed, or administer propofol. However, be sure to avoid large doses of propofol, especially in those patients who are hemodynamically unstable. Finally, be sure to treat any hypotension or bradycardia. If the patient is pulseless, initiate ACLS. It is important to note that the epinephrine doses change in a last-related cardiac resuscitation event. IV epinephrine boluses have to be reduced to only 1 or less than 1 mic per kilo. This is because when epinephrine is administered IV, it offsets the effects of the lipid emulsion and keeps the local anesthetic in the patient's blood system. You should also follow the OB/GYN's directions on care for the fetus and prepare for immediate delivery if the patient is unstable. Here I have included the lipid emulsion administration guidelines. You can see it depends on the patient's rate, and doses depend on if the patient is less than 70 kilograms or greater than 70 kilograms. Before administration of the lipid emulsion, you should double check these guidelines and double check your patient's weight. It is important that you do not exceed the 12 mL per kilo lipid emulsion. Last treatment typically does not require more than that and often responds to much smaller doses. The guidelines for lipid emulsion administration should be included in your last emergency crisis kit. Here is the last checklist provided by the ASRO website. This checklist should be available in your last toolkit and crash cart. It mentions all the steps we talked about on previous slides and includes an important section about after monitoring and care. It is important to continue monitoring the patient for at least 4 to 6 hours after a cardiovascular event, and important to monitor both the baby and the mother. If the patient experiences only mild CNS symptoms, they should be monitored for at least 2 hours after the event. Obviously, obstetric nurses are not caring for same-day patients who get a regional anesthetic and get sent home. A lot of factors would play into the aftercare scenario, such as if mom delivered the baby, and if she didn't, is she still safely laboring, or is she going to undergo a C-section? All healthcare professionals will have to work closely together, including the OB/GYN, you as the obstetric nurse, and the anesthesia providers, to develop a plan, and will need to continue to closely monitor the baby and the mother throughout.
Now we're going to work through a case study of a last event that occurred so you can get an idea of how this type of emergency could play out. Our patient is a 29-year-old prima gravid. She's 5 feet 4 inches tall and 87 kilograms. Her pertinent history is a congenital renal malformation. She has allergies to latex, levofloxacin, and ceftriaxone. She presented to the labor and delivery unit for a scheduled induction at 39 weeks, 3 days gestation. Her pregnancy has been uneventful. She has a normal physical exam, and her labs are all within normal limits. After induction is underway, the patient requests an epidural for her labor pain. The anesthesia team evaluated her for a continuous spinal epidural placement and decided to proceed with the procedure. The patient has been preloaded with crystalloid and is in a sitting position on the edge of her labor bed. Appropriate monitors are in place, such as the pulse ox, heart rate monitor, and blood pressure cuff. There is also a pre-existing IV. The patient is prepped and draped in a sterile fashion. 2 mL of 1% lidocaine is infiltrated into subcutaneous tissue at the L4 to L5 interspace. A Twee needle was then used to obtain loss of resistance. A 25 gauge needle was then advanced into the subarachnoid space. Cerebrospinal fluid was confirmed through a spinal needle, and 0.6 mL of 0.25% bupivacaine and 0.3 mL of fentanyl were administered intrathecally. The epidural catheter was then threaded, and the patient was placed in the supine position. A sensory test was done and revealed analgesia at the T10 level, or the level of the umbilicus. Negative aspiration was observed, and a 3 ml test dose was given. This contains lidocaine 1.5% and epinephrine 1 to 200,000. A patient-controlled epidural analgesic infusion of bupivacaine 0.1% and fentanyl 2.5 mics per mil was started at a basal rate of 6 mils per hour, with a bolus of 6 mils, with a lockout period of 10 minutes and a maximum bolus frequency of 3 boluses per hour. A single 6 ml bolus was delivered through the epidural pump immediately after the test dose. Vital signs remained stable, and fetal heart tones were reassuring throughout the procedure. 50 minutes after administration of the first local anesthetic, the patient reported tinnitus, or ringing in the ears, and a metallic taste in her mouth. The EKG showed narrow complex sinus tachycardia in the 130s to 140s. The blood pressure remained normal. She was placed in left uterine displacement position and given supplemental oxygen. She then reported palpitations, stating that something was off and that she was having an out-of-body experience. A presumptive diagnosis of LAST was made, and the PCEA infusion was stopped, and 1.5 mils per kilogram of 20% intralipid emulsion was given as a bolus, with an infusion started afterward at 0.25 mils per kilo per minute. The patient's symptoms resolved within 10 minutes of the intralipid emulsion administration. The infusion was continued for an hour after symptom resolution. The epidural catheter was removed, and the tip was intact, but noticed to be blood-tinged. The epidural pump record revealed a total of 24 mils of bolus deliveries. 2 hours later, the patient underwent an urgent primary C-section delivery for arrest of active descent. A repeat continuous spinal epidural was performed successfully at the L3 to L4 level without complications. The epidural was never dosed. I think this case study is a great example of the important role the bedside nurse plays in the role of recognizing a LAST event. By being aware of and recognizing the early symptoms of LAST, the nurse and anesthesia provider are able to take correct steps in order to stop the effects of the local anesthetic and prevent negative outcomes to the mother and baby. We hope you were able to gain knowledge about LAST and confidence in your ability to recognize and care for patients who may experience this life-threatening event. Thank you very much for participating in our DNP project. We really appreciate it.